Hello, my name is Alina Paegle, and I'm excited to give a short introduction into work that explores socio-demographic disparities in COVID-19 severity at the beginning of the pandemic in a Utah-based sample population. And while I'll be sharing this information, I do want to quickly recognize my colleagues who assisted and mentored in this work. Dr. Vanderslice, Dr. Benson, and Dr. Schleep. So a little bit of background. We do know that COVID-19 illness severity depends on complex intersection between a multitude of factors. However, it is clear that there are some who experience a disproportionate burden of severe COVID-19 illness. And while the magnitude of effect varies due to numerous social and structural determinants, it is identified that racial and ethnic minorities, those who are born male, and those of advanced age make up a disproportionate number of COVID-19 cases, those hospitalized for COVID-19, and those who died due to the illness. But illness severity is a bit more than just percent of cases and percent positivity, hospitalization rates, and case fatality. So keeping that in mind, the purpose of this study is to describe differences in COVID-19 outcomes in a Utah-based sample population by racial and ethnic identity, age, and gender. We did so by examining differences in the likelihood of severe illness along an expanded severity index that isn't just this cases, hospitalization, and fatality measure. Additionally, we describe differences in length of stay or length of healthcare interaction by these socio-demographic characteristics and severity index. This retrospective cross-sectional study utilized clinical data collected by the University of Utah on individuals who were tested for SARS-CoV-2 between March 10th and July 10th, 2020. And so to quickly highlight a few key results, of the almost 71,000 adults tested, a total of 6,445 individuals tested positive and were eligible for this study. On the right of this slide, you can see the severity index triangle. From bottom to top on the left side of the triangle, you can see the counts and percentages of each severity index from least severe at the bottom to most severe at the top. On the right, you can see the median length of stay for individuals in hours and in days stratified by severity index. Please note that those who were hospitalized were further stratified into those who were mechanically ventilated and those who were not. And mechanically ventilated on this slide is indicated with that NV. So here's a visual representation quickly of the likelihood of receiving ED care and hospitalization as compared to outpatient interaction by race, ethnicity, gender, and age. So comparing those higher levels of severity to lower levels. The reference categories used for each explanatory variable can be found along the vertical lines on the left of the slide and summarized on the bottom of the slide. So ED care odds ratios are marked with squares and hospitalization odds ratios are marked with circles. So while I'll dive into the specific results on my poster, I do want to point out the likelihood of receiving ED care or being hospitalized for males as compared to those who identify as female with that green arrow there. These results show that males and females have similar odds of higher illness severity as compared to lower illness severity. However, differences in COVID-19 illness experience by gender are evident when looking at length of stay distributions, especially in the hospitalized illness severity category. For example, you can see that almost 80% of females have discharged from the hospital around 100 hours of hospitalization, So about right here, if you can see my cursor. While 80% of males have discharged from the hospital just after 250 hours of hospitalization. That's about a 150-hour difference. And while there's more, I don't want to take up more of the 5 minutes. So I just wanted to present some of these highlights. Feel free to look at my poster if you're interested, or reach out to me with any questions at my email, which is included on this slide. A special thanks to my co-authors, partners at the University of Utah, and for this symposium, especially during this historic and unprecedented time.